Hi, good evening, everybody. This is Dr. Zhang. I'm live with you guys today, and we are lucky to have Meredith and Matt with us today as well on the panel. This is the second week of our SBI breast imaging summer series. Today, we're going to talk about the high-risk lesions. So first, I want to have Meredith introduce herself.
Hi guys, I'm Meredith Byers. I'm a breast imager in St. Louis, Missouri. I work for Washington University on the community side, managing the breast imaging centers at 2 of our hospitals. I'm so happy to have you here. We're going to talk about a lot of stuff. We would love you to share questions. We'll answer them as best we can, and we just really appreciate your time.
Great. Thank you so much, Meredith. We are very lucky to have you here today with us online. And then I also have Matt online. Matt, could you please introduce yourself as well?
Hey guys, it's me again. Thought you'd get rid of me last week, but I'm back. I'm happy to be here, excited to be here. I'm excited to get into some details about these high-risk lesions. And I'm if you don't remember, I'm a breast imaging radiologist in Pittsburgh, Pennsylvania at Allegheny Health Network.
Great. And we are very happy to have Matt with us again because he had such great input from last week. And just last but not least, a little bit about myself. So I'm graduating from residency. I'm currently a radiologist and I'm going to join University of Pennsylvania for breast imaging fellowship. So very lucky to have this opportunity to share some experience with you all. Today about high-risk lesion. First, we are going to talk about management because we know the management of high-risk lesion has always been evolving. And we're also going to talk about some temporary changes different institutions has implemented during the COVID-19 pandemic. So first, just to get everyone on the same page, I want Meredith to tell us a little bit about how you guys manage the high-risk lesions in your institution.
Well, so I think that's a great question and a great place to start. And I'll talk a little bit, but then I want to segue to Matt because he's got some insights really going to help with our discussion. Yeah. I was pointing out that I've been out of training for a while and management has changed since I finished training. And I bring that point out because as we are navigating through the breast imaging world and management changes, maybe your preferences change and you're working with surgeons, other imagers who have come out at different times. It's important for everyone to be on the same page. And that page may change each year, but it's important for there to be consistency. So when you are talking about switching from taking something to surgery to now watching it, perhaps as a BI-RADS 3, or something you would have recommended to follow one path and then you want to switch to another, you need to make sure your team is all on the same page. I'm sure there's nothing more frustrating to a breast surgeon than somebody who says, my patient has PASH, I'm referring her for surgery. And the next radiologist says, no, actually, we're not referring that for surgery. We can stop following that. So when you have two very different answers, it's really frustrating for who I consider our clients, which is our patients and our surgeons. So we've definitely moved from the way I learned, which was if in doubt or if high risk, go to surgery, to really putting patients back in at least a short interval follow-up, and sometimes recognizing that we don't have to follow them at all. Matt's got some really good information talking about some specific diagnoses, so I'll tag it over to him.
Sure. Mm-hmm. So when I was in training, mostly in residency, and then as we got into fellowship, we started transitioning, but it was still kind of in its infancy. But mostly during most of my training, it was like Meredith, where it was basically if you got diagnosed with any number of the high-risk lesions that were taught, that you just reflex go to surgery. Yeah. And as Meredith said, that's been evolving. Literature has shown that that's not always necessary for some of these lesions. Now, there are some lesions where, yes, the upstage rate is high enough to where it doesn't really matter if whatever, if you get it on a pathology result, you treat it like it needs to be excised. Such as atypical ductal hyperplasia, pleomorphic LCIS. I personally send papillary lesions to surgeons because, there are, some instances, some cases for papillomas where they can be followed, but I still have the surgeon decide that, because especially if they're palpable and it's a papillary lesion, that should come out. Fibroepithelial lesions, concern for phylloides, we excise all of those. But then there are some that have some gray area. Atypical lobular hyperplasia. If they're associated with calcifications and we feel like we adequately sample these calcifications, then we observe them. But if they're found with no calcifications, if we find them with an asymmetry or whatnot, then studies have shown that should come out. Some lesions, like Meredith said, don't even need to be excised, like flat epithelial atypia. Previously, we took those to surgery. Now, literature has shown that these can be observed. Mucocele-like lesions, PASH. If we see PASH incidentally and it comes back as PASH, we can observe those. Now, PASH has the tendency to grow and be deforming if we do follow-ups and say that's with an asymmetry and the asymmetry continues to grow, then that would be an indication for excision. But sometimes it doesn't. Sometimes PASH just stays stable, and that's not going to cause any harm. And this was all based off of literature. These recommendations that I have is all based off of literature that actually a colleague of mine, Lisa Sumpkin, she and I started at the same time at our job. She came to this job and saw that there was some variability between radiologists and between surgeons, as there are at a lot of different institutions. And the best way to cure variability between clinicians is to look at the literature and synthesize that all into a chart. So I have actually a chart that I was just kind of reading off to you guys that my colleague created. And it has really changed the way at least I practiced as far as high risk lesions go. And it really makes it kind of easier because it takes the guessing game out of it. We have these guidelines on this form that whenever we get a pathology result and it has one of these, you go to, after a while now at this point, I'm used to using this where I don't really have to refer to it anymore. But when it first came out, I could refer to this chart, and sometimes I'll still refer to it just to reinforce it in my brain, make sure that I'm 100% doing the right thing. But I encourage other facilities, other healthcare facilities to do what my colleague Dr. Sumpkin did, and go through the literature and basically synthesize all the recommendations, all the different routes you can take for all these different high risk lesions, because it really is helpful to know that some of the lesions don't need to be surgically excised and can be adequately watched.
Yeah, I think these are such great points because breast imaging has always been evolving. It's so important for us to keep up with the literature and always do evidence-based medicine. On the other hand, as you all brought up, there is definitely a surgeon preference. Like if certain surgeons just have certain preference, they feel more comfortable. So we are definitely willing to compromise that. And I think that's probably lots of people's personal experience as well. I know some institutions, they have their own institution guidelines just to make sure, try to get everyone on the same page. Yeah, and talking about high-risk lesion, another very important and also interesting points are the devices, because we usually localize those lesions for the surgeon to do surgical excision. And those devices has always also been evolving. Especially recently, people start to use Cs more often, so they don't have to do the same-day surgery after you put the Cs in. Just want to say, what's your experience using different devices, and how do you like that, what's the pros and cons you feel about different devices?
I want to jump in real quick, and before I get to the devices, I wanted to agree with you, Jill. And all of this organization or whatnot would be for naught if you don't have buy-in from your surgeon colleagues. So yeah. we need to have as breast imagers, any decision that we make going forward, treating lesions and managing lesions, it has to be in concordance with what our surgical colleagues, what our pathology colleagues, what our oncology colleagues agree with. And so if we just, as radiologists, try to take what we think is right and just kind of do our own thing, and it's at odds with what the surgeons are doing, or at odds with what the pathologists or oncologists are recommending, then there's still going to be that disconnect. So I think it's really important when you do something like we did here at Allegheny Health Network and create kind of a, and that's really what happened in the fall was that, you know, Dr. Sumpkin had not only buy-in from her radiology colleagues, but she went and talked to the surgeons and you know, got the approval of the surgeons and all the other medical colleagues. And I think that's really important to get buy-in from all of our other, you know, non-radiology colleagues. So as far as, and I'm sorry, Meredith, I don't mean to kind of you know, plow through the discussion here, but since I'm talking, as far as things that we use to localize, the main two things that we use at our facility is the radioactive seeds and wire localization. Now there are, you know, pros and cons to both of those. I tend to prefer the radioactive seeds because it gives you flexibility with scheduling. I think it's actually easier to place. And, you know, it's better, in my opinion, for the patient. They don't have something sticking out of them. We stick a needle in and, you know, to the patient's perspective, they're done. You know, they have that localizer inside of them. There are some new cutting edge materials. And I say cutting edge over the last couple of years. It's not really, you know, they're the newer stuff, the RFID, which is a radio frequency pulse that we've been workshopping here in Pittsburgh. And I think to great results. I really enjoy them. I think they place, you know, similar to a seed, but without the radioactivity, which is a benefit. And then there's the Savvy Scout, which uses sonar or radar. And I don't have as much experience with that, but I do know that they're very similar in their, from a radiology standpoint. I don't know if Meredith, you want to.
Sure. And so Matt, with the RFID, what do you think the future is with that? When are we going to see that as an opportunity of something to use?
So we've been using it now. We've been,
okay.
It's not our primary thing. And again, with all of these localizing techniques, you have to have surgeon buy-in, right?
Exactly.
And so there are some surgeons that haven't even converted to the seed because they like the wire. And so if we know that, you know, Dr. X is the surgeon, Dr. X likes the wire. And so, you know, that creates an issue, not an issue, but that just, we know that patient can't be scheduled for a seed. They have to be scheduled same day for a wire. With the RFID, you know, we haven't got to the point to where it's ubiquitous throughout our system. We, you know, in order to get it approved, we have to do 10, I think radiology has to do 10 I'm not sure the exact numbers. But we're currently going through the process and then COVID hit, right?
Right.
But I placed 4 or 5 of them. The big difference between the RFID versus the seed is the needle is larger.
Okay.
So that was a little bit of an adjustment. It's almost like sticking someone with a McDonald's straw is what I was saying, but it's not.
And is that harder on the patients?
Well, it's, you know, the patient's numb, so the patient doesn't really notice it either way. It is a bigger needle. It's a thicker needle. I didn't seem to have any issues with it. The patients that I didn't seem to complain about it. It's you know, you just look at it and be like, wow, this is a bigger needle. But it worked well. The surgeons that you know used it after I localized seemed to like it. So I think that's a benefit if places can, and from what I've heard, the Savvy Scout is similar. I haven't had any experience. It's just the benefits of not going through all the radioactive stuff that you have to go through with placing the seed is very beneficial.
It's a good point. And I think that, especially as we're talking to people who are coming out of their training recently, even for Jill to know that this is an evolving process and the product we use now may very well not be the product you're using 5 years from now. It's something that we use both the seed and the wire. And it's something I have the benefit of rotating at our academic campus where I get to teach the residents and fellows, and then being in our suburban campuses, which is more of a private practice community feel. A couple of things are really important. Number one, like you said, your surgeon preference. And Jill, when you ask about the pros and cons, I'll tell you one of our surgeons really likes the seed and wanted to have it and really made it happen for our hospital. Another surgeon did not want to go through the training for it. So for her, that was a non-option. So the pros and cons are your surgeon has to be on the same team that you are in terms of what they want to use. We then have surgeons who prefer different wires. And so the next people who have to be on your team are your technologists, or the people doing the procedure with you, because everybody needs to check themselves. Okay, we're doing surgery for Dr. X today. We need to make sure we have this equipment. We need to make sure we have it scheduled on the same day versus we need to schedule this patient ahead of time. And then you have to have if you have a nurse navigator or a nurse that works with you, or somebody who's coordinating with the patient with their surgery time and their plan, who's connecting all of that for the patient, so they have the same expectation. And I mean, it's a lot. It's very much a team approach. It comes down to your team. The one thing I would say, and I'm satisfied with both the seat and the wire, and I'm happy to try the RFID. So it's just, I love learning one more new thing to do. But even for both localizations and for your biopsy devices, because part of what we're discussing here, biopsy devices come in, and we all know there's a huge variety of those out there, and they're also evolving. The device we were using last year, we were supposed to change it in January, and then of course everything hit as of March, and so we just got it in earlier this week. So I think it's important for our residents and fellows and our newly graduated trainees to get your hands on as many devices as possible. Don't be scared of them. Don't think, oh, I haven't used that before, so I can't use it. Connect with the product reps, connect with your technologists, but get as much training, because wherever you go, I promise they're going to use something different than what you're currently using. So the more coals in your belt you can put with, I've seen that one before, I've tried that, or I prefer this one to that one, but I'm comfortable using both, makes you a more attractive candidate, makes you a better radiologist, and really makes it better for your patients.
Yeah.
So
yeah, those are all such great points, because I think I also talked with some surgeons, like a leadership, they sometimes like to use the seat because they feel like they save the OR time. Like for them, if they have like empty OR for 30 minutes, it's a big deal. So they would rather, if patient's insurance doesn't cover, they would rather share the cost with the radiology department to do the seat. And but then as you said, they do have to go through certain trainings, and certain surgeons are more comfortable with certain devices than the other. And we do have to work with them and see what's their preference, what's the best for the patients. So lots of different things to take into consideration. And one of my surgeon friends was like, if it's a very experienced radiologist, when they talk to them for things they are not sure, it feels like talking to another surgeon. So I think that's a big compliment for us too.
Absolutely.
You know, this is so well, then they treat you as their equals, and they really like take your opinion into consideration. So I think that's really good for us regarding job satisfactions. Also regarding those devices, I think it just like keep evolving, and some of them are more expensive than the others. So cost is also like a big thing as well. I think, as you all said, especially some radioactive ones, some institution may have problems following the guidelines in case they lose a seat or stuff. And then so very, very interesting field, actually. I think in the next few years, we probably will see, as Meredith also said, we probably will see more devices. It's never going to be the one that you trained that you're going to use.
No, it never will it? And I think, that's probably, to me, one of the saddest parts of looking towards the rest of this year is I really enjoyed RSNA for the chance to go get my hands on equipment, to be able to sample everything that's out there. That's obviously not happening this year, but that has, for me, been a real game changer in deciding what product we're going to try next. So let's hope we can get back to that, because it's really important as a radiologist that you feel a comfort with our devices, so that you and your patient and your surgeon are all being served well.
Yeah, absolutely. I feel like RSNA is such a platform for us to shop for new toys, and so this year will be virtual. We'll see. We'll see how that part turns out. So regarding, everything turns virtual. So how that has changed regarding your high-risk lesion management with this pandemic? I know certain places has been postponed some procedures. Just want to see what's your personal experience.
Well, I'll go first. It's been it's sort of been a tale of two cities, right? when we went into shutdown, we continued to do diagnostics, procedures, and some surgeries. Not every surgery, and if it was safe to postpone them, then the surgeon and the patient chose to postpone it. And so our work day was really almost cut in half. We weren't doing screenings. Now that we're back up and going, well, I mean, I feel like we're at the start of the Boston Marathon, and they just started the race, because it's like a trample to get there. And a couple of things. I think there's no one right answer. Okay, so you and your practice have to decide what's going to work for you. I will tell you that while I heard from various manufacturers that patients were scared to come back to the hospital, that's not been my experience. Patients are ready and anxious, and they want to come back, and they're actually more anxious at the fact that they haven't seen us in the last 3 months, and did that delay, and we'll talk about that at a future session, but did that impact their lesion and their process? So we're trying to really, almost like a boutique type practice, individually manage each patient. So it's not just about the lesion, it's about the lesion and the patient and her history and her mindset. And so if one is still saying, I'm not sure, is it okay if I wait a couple more weeks to come in? Absolutely. But if the other is saying, even though I know this lesion you told me it was probably benign, I was supposed to come back in 6 months, it's really been stressing me out. Okay, we'll bring you back sooner. So it's really been for us a case by case decision. And what we did on Monday doesn't always match what we're doing on Friday, because it's just such an evolution. I feel like we have at least in our practice, we have kind of a game plan that we talk about on Monday morning, and then on Friday evening, we revisit and like what worked, what didn't. Okay, how can we manage these patients more efficiently? How can we get them in so they can be seen sooner? Who are we overlooking that we need to think about? So anyway, it's just been a very dynamic process for us.
Absolutely, Meredith. And that's such a great point that you bring up with you're not only treating the lesion right now, you're treating the patient, because not every patient is handling the situation the same as each other. And I think that's important to not lose sight of that as you are going along and, running a breast center and seeing, like you said, treating it like a boutique. I'm just kind of reiterating what you're saying, because I agree with everything. I absolutely agree with everything. And, when COVID first hit, we stopped all screening, and we really, stopped all high risk treatment. The surgeons were only surgerizing cancer. And up until the middle of May, it was like that. And so there was a backlog of high risk lesions, that developed. It wasn't, it wasn't astronomical, but it was enough to where, there needed to be a catch up. And, now, we're back to, we can offer, treatment or diagnostic stuff to anybody right now who wants it. But, we have, I was telling people last week that last week was my busiest week since, the late November, when people are trying to catch up for their insurances rolling over in December. It was a madhouse where I was at. And that's just, people are ready to come back. People are ready to come back and get what they know is the right healthcare for their breasts. And, we were talking last week, that doesn't just that doesn't just apply to breast. I mean, people are ready to come back and get all their other healthcare maintenance stuff, colonoscopies, blood pressure checks, seeing their PCP. And, I think I kind of got off tangent on what the original question was, but the long and the short of it is that there was a two-ish month delay there in the treatment of high risk lesions, and now we're back treating them. And it's important for patients to know that, if it was recommended that, you should get this treated, that whenever you feel comfortable coming back to the hospital, that we're ready for you.
Yeah,
absolutely. We're ready for you, and we're actually over prepared. We've made our place the safest it could be. And I'm sure you guys are in the same scenario that we are. We're actually doing more exams now with fewer staff, because we've had some furloughs. And so we are really playing the catch-up game, and we'll be there for a while. I think it's important, if you have a way to review your patient population who missed their exam during this time, if you have any sort of filter or
absolutely
ability to look back, and remember, these are, I think of these as our clients. These are our business. And it's the beauty of breast imaging is that it's both an art and a science. The science is we need to get everybody back. The art of it is looking through your list and saying, hey, actually, this one needs to get back sooner than that one may. And if you can partner with somebody in your practice who's able to connect with the patients, contact them, send a letter, whatever you can do. We recognize that patients coming back don't know what the new COVID normal looks like in our breast center. So they are anxious and itching for that connection for you to say, we're paying attention to you. We want to see you back. We've done all these things and we think it's time for you to come back. They're really ready for that.
Yeah, I think those are really great points. Especially, actually, my next question was about how do you prioritize those patients, because there is such a backlog. And I think you guys bring up such a great point. It's not just bring them back based on the lesions. It also depends on like how the patient feel, because we want to do patient-centered care. If certain patients just feel like more uncomfortable, and we do, try to make the efforts to bring them back a little bit sooner. And also, everyone has been like ready to try to get those patients in so we can, make them feel more comfortable. But just curious, what are the questions and the concerns? So patients usually ask you since they did have a delay. So what are those questions and concerns that they brought up when they come back?
For me, I haven't had much in the way of questions, concerns. People, I was thinking about this actually the other day, people that have come back that have had the delay, that was originally you were recommending a 6-month follow-up and now they're coming back in 7-8 months, right? Yeah. When I go in and talk to these patients, they understand that what happened was necessary. What happened, and in the rare case, I think I've only had 1 or 2 instances to where the patient that have been that had a recommended follow-up and that now we're upgrading it to a biopsy.
Yeah,
they understand that it wasn't just, we weren't just telling them to delay just for the sake of delaying. We were doing that. I mean, it was a necessity. We had to flatten the curve, right? And that obviously there hasn't. We don't know if there was a problem with the 1 to 2 month delay in diagnosis. There hasn't really been time enough to study that right now. But I assume, just from being a breast imager, that if there is an effect, that it was a minimal effect on those few lesions that happened to have a delay in, a 1 to 2 month delay in diagnosis.
Yeah, I completely agree with that. I will tell you a couple things. I think we also have to recognize the mental anxiety that COVID has imparted on everybody, patients, physicians, etc. So most of my patients are not worried about the delay, but are happy to get back in. I have others who have been stressing about their BI-RADS3 lesion and have said, okay, can I come in now because it's all I've been thinking about? Many of those are my patients who have a history of cancer, either recent or remote. And so this time at home in isolation has really ramped up anxieties. And so that's why I talk about the boutique practice of your BI-RADS3 might actually be more important than her BI-RADS3, so that you can both be seen in the right amount of time. So we're trying to approach it from that. And also, I think our journals for the next year are going to be talking about what this 2-month delay did to our patient population, to our numbers, to our stats. Yep. If you're watching this call and you're going to keep watching, that's one of the things I'm going to talk about when I do my talk in August is, what did this do to equip? What did it do to our yearly inspections? How are we all navigating some of the details around it? But I think this is going to be a subject that's we're talking about for a while.
Future plug right there. I love it.
Yeah. Yeah, I think that's such great points. It's like very individual based, like how people handle this, because it's just very stressful for us too during this pandemic. Lots of people actually got redeployed to different fields just to fill the
Were you
gap.
Redeployed, Jill?
We are just about to, and then the curve start to like go down.
So you're right on the cusp, huh?
Right on the cut, yeah, right on the cut. So I think also just want to say, sometimes we do have an upgrade of the lesion after biopsy based on pathology.
Mm-hmm.
And do you do anything different because there's a delay? Would you recommend some additional imaging, at this point with all those patients coming back?
I'll let Matt go first on that because I'm interested to see hear what he says.
I haven't had that yet, to be honest with you. I haven't. I mean, I was just thinking, conceptually, what I would do. If you have a high risk, say you have an ADH, and it was upstaged to DCIS. Assuming they didn't take wide local excisions, and they came to me and said, what imaging, I would get an MRI. I would have low threshold for getting an MRI. Yeah. Just to see if there's surrounding enhancement, see if there's other findings in the breast that are concerning. But I really haven't encountered that yet. But I definitely, as a global comment, I would definitely have a low yield that would be the next step, would be to get an MRI and see what it looks like.
Yeah,
I think that's so interesting you say that, because when we went into our shutdown, really breast MRI went off the table. We weren't doing them.
Absolutely.
The minute we opened back up, it was like a breast MRI party. We're doing them all day, every day. You get an MRI, you get an MRI, you get an MRI.
Yeah.
What's been interesting about it is I'm like you. I'm actually I'm finding myself more liberal in recommending it that I was going in. In part, it's a business strategy. It's an exam that I think is worth its weight in gold. Sure. So if a patient can get it, I want her to get it.
Sure.
Also, we've got space on the magnet now that we maybe didn't have 6 months ago, and we may not have 3 months from now. Mm-hmm. So trying to take advantage of just the timeliness of that. But also, I feel like patients, especially in I would use it in my younger patients, the under 50-year-olds, they're really desirous of having one. They've read about it, they know about it, they want to know if this is appropriate for them.
Absolutely.
So we're trying to accommodate as many of them as we can. Mm-hmm. So that's probably the one exam that I feel like I'm pushing a little bit. So
absolutely. I don't think you're wrong in that standpoint. I mean, I wouldn't say that I'm pushing it as more or less than I have in the past, but like I said, I would have a low threshold dealing with all this stuff. If someone comes to me and I might use it more for problem solving now than I would in the past.
That's exactly right. That's how I would phrase it. And I'll actually tell you, when we got back to our resumed normal schedule, and that first breast MRI came across the list, I kind of did a whole happy dance. I was so happy to see it. Like
I definitely did that for a screener too. Like I as soon as I started seeing the screening list I'm like, holy crap, we got screeners again. This is awesome.
Exactly. Like I had missed them. I didn't realize that I was so attached to them, but I missed some of my friends, and now my friend exams are back. So anyway.
Yeah. I think also that probably put patient at ease too, because with this delay, some patients may be more anxious, especially as you guys said, they had a breast cancer history or they have like strong family history. With this delay, they may be more concerned about the extent, the extensive, whether the lesion become more extensive over time. So, it is actually a good point. We have great tools like breast MRI, so we can take a closer look in addition to the memos and ultrasound that the patient may be getting. I think we had a great discussion today. I feel like I learned so much from both of you. Just want to see any last few words you guys want to add before we end the session.
I'm actually going to throw out a question for you two. That I just want to hear your opinion on it. This is not about a high risk lesion, but about benign lesions. I've been trained that apocrine metaplasia is a benign lesion. I am finding that I have more and more patients asking about it and what they need to do about it. So I'd love to hear how you guys approach it, and if maybe you do something differently than I'm doing.
Well, I can start. It depends on the concordance of the biopsy. If it's concordant, if I feel like it's apocrine metaplasia, it's benign to me. There's no follow up.
So you're not putting them back in short interval follow up after that?
No. Okay. It's a case by case basis. I would have to see the image findings, but if I'm comfortable with that biopsy result, then I don't do anything else with them.
Okay. I think it's
no, go ahead.
Go ahead.
I think
go ahead.
some of my attendings follow up. like if benign, some of them follow up 6 months.
Mm-hmm.
I find we have, for us, one of our surgeons likes to follow that up. And again, I completely respect that. But I always think, is there something I'm missing that maybe there's a reason to do it and it's not on my radar? So you guys seem like great people to ask.
It's just, that was how I was taught. And, you know, like I said, you know, occasionally I'll think, you know, I don't like how that looks. And, you know, that,
yeah,
I might follow it up that way. But if I'm just, if it was an iffy lesion to begin with and it came back apocrine metaplasia, then I'm just like, you know what, that's benign. I agree with that. It was an iffy lesion to begin with. I'm good with it.
Yeah, you really have to know what your comfort level was with it going in.
Yep.
So I completely agree.
Yeah. So Matt, any questions or any last few words you want to add?
No, this is great. You hit it out of the park today, Jill. You were a much better host than that buffoon last week.
No, I learned from you. I learned from the best. That's why.
No, it was a pleasure speaking with both of you. This is a blast doing this. I hope everybody watching had fun. I'm thoroughly enjoying this. Yeah, I can't thank you both enough for coming today and discussing breast imaging, breast health with me. This is fun.
Yeah, thank you for organizing this. If it wasn't you taking the initiative, we wouldn't have this opportunity to learn from each other. I feel like it's just so great to be able to learn from both of you today. And I definitely look forward for future sessions.
Absolutely.
Well, thanks, Jill. You're an amazing host. Congrats on your move. Good luck with the next stage. We're all rooting for you.
Yeah, absolutely.
Thank you so much.
Newly minted breast fellow there, Jill.
That's right.
Thank you.
Just a programming note, we do have another one scheduled next week. Dr. Malik will be our host, and I will not be on it, so you won't see me next week, so that'll be good. But I will be watching thoroughly, and I will be promoting it. So to everybody watching, we really appreciate it.
Yeah, thank you all so much. I really appreciate you guys joining, and also without your support, it wouldn't be such a fun session. So I have so much to learn from all of you, and I definitely look forward to watch thoroughly of the future sessions and also participating as well.
Thank you. It was awesome.
Alrighty. All right. We'll see you guys in future then.
Bye-bye.
Hey, bye.
Have a good week, everybody.